It's just so freaking awesome to have Dr. Tillman, Dr. Westifer, and Dr. Morgenstern back on the podcast for round 2 of management of pulmonary embolism. Between the three of them, I think our collective brains might actually explode. So I warn you, if you're anywhere away from a hospital, you might want to get closer to a hospital because your brain might explode by the end of this podcast. Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. First, just a quick word from our sponsor, Metricaid, the experts in complex physician scheduling since 2012. Shift work comes with its challenges, but Metricaid helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricaid.com/emcases to see how Metricaid can make your scheduling fair, improve your sleep, and your performance. That's metricaid.com/emcases. Are you ready for a new start or a next step in emergency medicine? Trenton Memorial Hospital in southeastern Ontario is hiring full-time EM physicians to join a supportive team making a real difference, where work is demanding but deeply rewarding. Earning potential is over $600,000 Canadian annually, with incentives up to $75,000 and flexible shifts. They offer relocation, licensing, and immigration support for eligible candidates. It's close proximity to Toronto, Ottawa, New York State, and Vermont, and minutes from wineries, beaches, and outdoor adventures. Visit quintehealth.ca, that's QUINTE health.ca, and click on Physician Opportunities. In part 1 of our 2-part podcast series on management of higher-risk PE patients with Lauren Westifer, Justin Morgenstern, and Burke Tillman, we discussed risk stratification and management of intermediate-risk PE. In this part 2, we're going to delve into management of the high-risk PE patient. So these are the sickest of the PE patients, about 5 to 10% of all PEs, but with a high mortality rate of 30 to 40% at 30 days. All of these patients, unless there are absolute contraindications, should be considered for timely thrombolysis. Now, the evidence for mortality benefit is quite clear in these high-risk patients, and this is guideline recommended when it comes to thrombolysis. Now, there are lots of nuances in the management of high-risk PE patients as well, which we'll discuss. And just like in intermediate-risk PE patients, high-risk PE patients are a heterogeneous group ranging from the patient with persistent systolic blood pressure under 90, which is sort of one of the definitions of high risk, and then otherwise looking pretty well. So they range from that kind of patient all the way to the patient in cardiac arrest. And of course, we're not going to be treating the patient in cardiac arrest the same as we treat that patient who has a systolic blood pressure under 90 but is otherwise not too bad. For this part 2, we're going to do the same case that we did in part 1, but with a little twist. We had a 30-year-old female on oral contraceptive pill who was satting 68% on room air when EMS picked her up after 6 hours of shortness of breath and a syncopal episode. She had an ECG and POCUS suggestive of a right heart strain. She was started on IV heparin and had a saddle embolus on CTPA. This time, however, instead of just being admitted to the ICU, she comes back from the donut of truth, satting 88% on a non-rebreather with a blood pressure of 70/40, and now she has an altered mental status. So our patient has now evolved from an intermediate risk PE that we covered in part 1 to a high-risk PE, which is the topic of this podcast. So, Dr. Tillman, you eloquently outlined the pathophysiology of PE in part 1 of the podcast series, but I just want to reinforce here how the spiral of death happens, because this is what we really worry about in these high-risk patients. Could you just review for us quickly how hypoxemia and RV ischemia, decreased RV contractility and output, decreased LV preload and output all leads to worsening shock and death, which is essentially our pre-arrest patient's situation?
Sure thing. So the way I always think of pulmonary embolism is the idea that the LV is not seen flow from the RV because there's something physically in the way. So as the disease starts off, there is a blood clot that's blocking the outflow of the RV, and this increases the blood pressure that the afterload the RV needs to see. And the RV itself is actually a pretty weak muscle. So as it has to work against a higher afterload state, that's pulmonary vascular resistance, it starts to fail. And when the RV failed, it dilates. From the end of the bed, though, we don't see that. What we see is the blood pressure gets worse. So we do the usual things that all good clinicians do. You try and resuscitate your patient. And as we discussed last time, the RV is quite sensitive to fluid. If you don't have enough fluid, it's a problem. You have too much fluid, it's a problem. And so as we start to resuscitate this patient, the RV can actually dilate more. And this causes a number of problems. One, the RV gets larger, it gets harder for you to get oxygen to the RV through the RV wall, so it gets more ischemic and more dysfunctional. And also it starts to push into the LV. So now not only is the left ventricle not getting enough fluid because there's this darn blood clot in the way, but the left ventricle actually is a smaller space because the RV has gotten bigger and takes up space. So the LV doesn't fill as well, and there's less space to fill. So we're seeing at the end systemic hypotension. To make this even more challenging is the way that pulmonary vascular resistance works. Is not only is there this blood clot in the way, but if the patient starts to get hypoxic as they go into shock, they decrease their mental status, their oxygenation goes down, and the pulmonary vasculature is smart. If you have hypoxemia, you get sort of your hypoxic vasoconstriction. So now you have hypoxic blood vessels that have vasoconstricted. You have other blood vessels with a clot in it. So there's even more afterload that the RV is seeing. So the RV just keeps getting worse, and we tend to give them more fluid, which at this point may actually be harmful. It gets bigger, and things just get worse and worse until you intervene by starting to give them oxygen and deal with this blood clot. That's the overarching reason that they've gotten sicker.
Beautiful. So essentially, RV dilates because the clot is sitting nearby. It bows into the LV. There's decreased cardiac output. That leads to more ischemia. The more ischemia, more RV dilation, the worse the RV is. And it's just this rapid spiral, and that leads towards death. And we need to prevent that, which is what this podcast is all going to be about. But before we get into how to actually prevent that spiral of death, I just want to dive into the categorization and definition of what kind of PE we're dealing with when we're talking about high-risk PE. We used to call it a massive PE. We shouldn't be calling that anymore because we don't want to confuse each other. So just to go over that, a high-risk PE, what used to be called a massive PE, is delineated by one of three things. It's either cardiac arrest or the presence of obstructive shock with a systolic blood pressure less than 90 or use of pressors to maintain a blood pressure of 90, and evidence of end organ ischemia like altered mental status, cool skin, oliguria, and increased lactate. And then the third thing is persistent hypotension with a systolic blood pressure less than 90 or a drop of 40 or more for longer than 15 minutes, not explained by an alternative cause like sepsis, for example. So we'll have that all in the show notes, but that's essentially what we're talking about when we talk about high-risk PE. Dr. Westifer, can you explain how you subdivide the high-risk PE patients further to help management and why that's important? We talked about how they're a heterogeneous group. How do you think about these different high-risk PE patients in terms of dividing them into groups so that you know how to manage them properly?
For me, I think of it in really three buckets. The first one is you have a patient who has died. They're in cardiac arrest. And that's important because you need to act right now. So from an action standpoint, you have no time. You have to act right now. Your decision points are limited. The second is that patient that is peri-arrest. They are on 100% FiO2. They're tachypnic. They're working to breathe. Their blood pressure is very low despite whatever you're trying to do. You've tried to fill their tank. They're on pressors. You've looked at other causes and it's not sepsis or something like that. Their lactate's up. That patient is going to crash with just the littlest tip in their hemodynamics. They're compensating until they're not. And the third is the high-risk non-peri-arrest patient. So the patient that looks pretty good when you're evaluating them. They're warm, they're perfusing, but maybe they are on, I think something that's not captured in this current risk stratification schema is the oxygenation status. So for example, that's not part of any of the high risk PE, but sometimes you have a patient who their respiratory status is garbage. They're actually high risk, but they're not peri-arrest because you're able to put them on sufficient oxygen. So I put those patients in this bucket, although it's not technically part of this schema unless they have an elevated lactate and other things. This is also where your patients who maybe have relative hypotension but are looking pretty good, their lactate's bumped, that's where these patients go. They're not really peri-arrest, but they are higher risk because they have multiple features that are tipping them towards that RV death spiral.
So just to clarify there, you've got your arrest patient. That's straightforward. You've got your peri-arrest patient, and then you've got your high-risk, non-peri-arrest patient. But to clarify the oxygen saturation part, so someone whose respiratory status is terrible, but they would be placed in the high-risk, non-peri-arrest patient. If they're really terrible, you think of them as more peri-arrest. Is that right?
Yeah, I mean, it all depends, right? If you don't want to put these patients on non-invasive ventilation and increase their PEEP unless you have to, and sometimes that's your next step, and then that may be what tips them over the edge in their spiral. And so for those patients that really are requiring a lot of respiratory support, not just a few liters nasal cannula, those aren't the patients that we're talking about. These are the patients that are really, they get very breathless and their oxygen requirement goes up with any movement in the bed. Those are these type of patients. They're higher risk. It's not the patient that just has a bump in their troponin or a bump in their BNP or is on a couple liters. These are those type of patients because, again, they are going to get hit by that spiral just by increasing their support with PEEP or whatnot.
I want to talk about management goals in the peri-arrest patient. So the patient that we had at the top of the cast is peri-arrest. So Dr. Morgenstern, what are the goals of management in the peri-arrest PE patient, like our 30-year-old who was started on IV heparin, is satting 88% on a non-rebreather, and their blood pressure just dumped to 70/40?
First, let me just take a very big step back here. And just as a reminder, very few of our PE patients are going to present like this, right? Medical textbooks are always written like this. You know the diagnosis and let's move on from there. But almost all of our patients are undifferentiated. So you take the exact same patient, hypotension, hypoxia, but without the CT results. And that's what we're going to be dealing with most days. And honestly, almost all of our cases, we're going to resuscitate these patients exactly like we always would. And we're going to at least start there. And every emergency clinician knows how to manage hypoxia. We all know how to manage hypotension. So as we go through this podcast, I think the key that everybody wants to listen to is the subtle differences from a normal resuscitation, because how we manage right ventricular failure is different in a couple of important ways. And so I think actually the key lesson here is just always in the back of your mind in every resuscitation, just think about that RV, because it's not just PE. It could be a right-sided MI. It could be a valvular disease. But whenever a really sick patient goes through the door, just keep in the back of your mind, is this the RV? And then there's a few key differences that you'll hear about. And really there's three in my mind. It's the decision to intubate, the decision to use PEEP, and the decision to use IV fluids. And we'll discuss all those probably in a little bit more depth. So aside from that big aside, I can't answer your question. What are my goals of care for this sick patients with a confirmed PE? And I think first, Lauren already sort of said this, but don't succumb to anchoring bias, right? PE is very often a secondary diagnosis. Patients who are septic first can develop a PE afterwards. Patients with bad COVID get PE all the time. That PE might be from a right-sided endocarditis. Our patient had syncope. Maybe they fell. Maybe her belly is full of blood. So don't jump to the diagnosis of PE, even with a confirmed PE. So step number one is run through a differential diagnosis. Use your ultrasound rush protocol. Make sure the diagnosis makes sense. A large saddle embolus with a huge IVC. Yep, I believe that PE is the cause of the hypotension, hypoxia. Smaller PEs, flat IVC. I'm going to keep searching for another cause. And then honestly, I just run through my standard ABCs with those three caveats I mentioned. So airway usually is not a problem in a PE. Plastic between the cords isn't going to help any of these patients. So my focus is on basic airway positioning. We're going to delay intubation if possible. Breathing, we're all very good at managing hypoxia. I think there's two things to keep in mind. Number one, PEEP is bad in these patients. And number two, we all focus on the hypoxia component because that number's flashing at us on the screen. Ventilation, not as much in the initial resuscitation in emergency medicine often. And because of pulmonary vasoconstriction, hypercarbia, acidosis, that ventilation piece could be pretty important when you're managing the B part of the ABCs. Circulation, again, we know how to support the blood pressure, but again, our instinct often is to flood people with IV fluids, and IV fluids can make that RV worse. So if we know for sure that PE is the issue, we're going to try to limit the IV fluids. But again, there is a broad differential diagnosis. So I have no problem if you're going to try a few small boluses and just watch what happens to the patient. And then finally, after we run through those basic ABCs, you got to remember the ABCs really are only temporizing here. And so we have to solve the underlying issue. We need to get rid of that clot. And that's usually going to be thrombolysis, but there are some other advanced therapies that we can talk about out there. So as we go through the details, I think people are going to think this sounds a little bit complicated at times, but I think it is not. It is the usual ABCs with 3 big caveats. Try to avoid intubation as much as possible, avoid PEEP as much as possible, and avoid IV fluids as much as possible. Then treat the underlying cause. And those are our goals. It's not that complicated. And I'll tack one thing on at the end, right? Once I've done through my ABCs, I've done my supportive care, my thrombolysis, always got to be thinking about that next step. Who do I need to get involved? Is there a role for these fancy, inhaled pulmonary vasodilators? But more importantly, what advanced therapies? Do I need interventional? Do I need surgery? Do I need ECMO? Thinking about that early helps you sort of set the stage for where things are going to go over the next hour or so.
Brilliant. I love it simplified down to it's your usual resus, except the decision to intubate is going to be a bit different. The decision to use PEEP is going to be a bit different. And the decision to use fluids is going to be a bit different. And then, of course, the thrombolysis and addressing the actual clot. Dr. Tillman, anything to add or any disagreements about that approach?
My approach is pretty similar. The challenge, and this has been a challenge for 30 years, is PEEP. Like many people have made their career off of trying to identify what is appropriate PEEP. And so the idea comes down to you want to ensure that the alveoli that will participate in gas exchange, so the ones that aren't involved in the VQ mismatch, that actually are going to be able to diffuse oxygen and CO2 through their bloodstream, are able to function. So likely if you make it to the intubation, which hopefully these people don't need, I very have not in the past dozen years run someone on ZEEP, which is zero PEEP. So the idea being, we don't know how to measure optimal PEEP. There have been esophageal balloon pressures, still hasn't gotten our perfect idea there. So I think what I want to do when providing supplementary oxygen, ideally I want to do it in the least invasive way possible, which is why I'm a fan of high-flow nasal cannula. If I've sort of made the decision that they are hypoxic despite those interventions, it's ensuring that however I'm delivering oxygen, if it's to a non-invasive or invasive format, when we think about PEEP, and this is the nuance comes, it's not avoid PEEP at all costs, which I don't think Justin is saying. Rather, it's as you're adding on PEEP, it's ensuring the PEEP you deliver is what is needed to open the alveoli that are going to participate in gas exchange. And so really, I think in my mind, are the reasons why their alveoli are going to be overly compressed? Like, did they vomit while they were sick and now there's a bunch of aspiration, you're overcoming fluid in the lungs? Is this someone who has a large chest wall? Like, why would I need a bit more or a bit less PEEP? So I wish I could give you a number. I wish I could say, run them all at 5 of PEEP, run them all at 15 of PEEP. There is no magic number. So in your brain, what I think is, think of these balloons of alveoli. You want them nicely opened to avoid as much of that hypoxic vasoconstriction that increases your pulmonary vascular resistance. Because what we do know from looking at our patients who have right-sided heart failure from a PE or any other cause is once they get hypoxic, it's incredibly hard to get out of that, and you really kick off that spiral of death. So I think in my mind, if you've gotten past high-flow nasal cannula and you're going to be applying PEEP, it's a shame you're here. That's a hard situation. Probably get some friends involved. And think in your brain, what are you trying to do with PEEP? You want the good alveoli open. How much does that take? And unfortunately, there's no gold test to tell you. It's real challenging.
All right. So bottom line there is you're going to be reaching for high flow if your patient's not doing well on a rebreather. That's kind of our go-to. That would be considered sort of our first line if they fail all the usual things. We want to try and avoid intubation and lots of PEEP, like with BiPAP, for example, or intubation. I want to talk a little bit more about if you are in that situation where you do need to go for intubation. We want to avoid apnea because that's going to make things even worse. It'll precipitate RV failure and lead to a cardiac arrest. If you do need to intubate this person, how are you going to approach that situation?
So I'm going to go back to Justin's statement is everyone in emergency medicine knows how to resuscitate people and do what you do most commonly when you intubate these people. Yes, there'll be a little things you can try and do to finesse it, but now is not the time to learn a new technique. These are sick patients and they can be challenging from a hemodynamic standpoint. So I would stick with what you're best at. As far as, okay, what are some of the things we want to avoid? So I think, Anton, in your introduction, you nailed it. Like, we want these patients to not get hypoxic. Once they get hypoxic, it is challenging to stop that spiral. I will ventilate a lot of my patients during an RSI. So whether you do this awake or you have someone paralyzed, like I'm going to be ventilating them through. A lot of the evidence shows that we are more likely to get that tube in faster if we use our RSI techniques. So if I'm trying to minimize that time where they have ineffective ventilation, I actually still am paralyzing these patients. I know there's discussion about should you do this awake and have them sort of breathing through. A lot of facilitated ketamine intubations, these people still hypoventilate. So often you're not avoiding hypoventilation by doing a facilitated intubation. So if you're really saying, I need this person awake and breathing perfectly, that's an aggressive topicalization and going down that route, which is at the best of times really hard, let alone in a peri-arrest patient. So when I'm thinking these patients, I'm going to stick to sort of my tried, tested, and true, which is doing an RSI. And then this is a hemodynamically unstable patient. So what drugs do I use in that? Well, I like to use ketamine in my hemodynamically unstable patients. And then once they're intubated, this is where we're trying to avoid over-distending and look at our best practices for ventilating these patients. So I'm using our low time volume ventilation that we try and use for any of our sick patients. So really to summarize, if they are hypoxic despite good conventional therapy, I'm saying, okay, this hypoxia is going to make the situation worse. How can I more efficiently, effectively deliver oxygen? I've decided that's intubation. As Justin said, the plastic tube itself, that's probably not what's fixing them. It's just being able to deliver higher concentration oxygen. I want to minimize how long it takes to get that tube in once I've made that decision. So for me, that is using a rapid sequence induction technique, but I am going to likely ventilate these people through this to try and ensure that I keep their oxygen levels high and potentially keep a couple more alveoli open. And it's understanding this is a hemodynamically high-risk intubation. Rather, often these are not anatomically challenging. It's the blood pressure is going to swing whilst you do this.
Fantastic. Any other tips in terms of if you need to intubate a patient, starting pressors before you intubate, anything else?
So anyone I expect to get hypotensive, I'm starting a pressor beforehand. I'm also having some push dose pressors. Like I will ask for whatever drug our team is most comfortable pushing. At my shop, that's phenylephrine people like to push. And as far as my first dose vasopressor, I'm still just using norepinephrine. So in this case, we had a patient whose systolic was 70. If I'm starting at a systolic of 70, I really want that number higher before I'm inducing and intubating you. So I'm going to run a vasoactive agent, for me, norepinephrine, get that pressure to as high as sort of I can. If I can get that systolic to 120, that would be fantastic. I suspect it's going to be real hard, but I'll try and have some vasopressor running in the background, as well as understanding there are going to be swings in the pressure. I will have push dose pressors, which at my shop ends up being phenylephrine.
Okay, we're going to get into way more detail about how to manage blood pressure in these patients. That was a question more specifically for if you need to intubate. I'm sure Dr. Westifer and Dr. Morgenstern have comments about if you need to intubate. These are very challenging patients. Dr. Westifer?
Just there's one simple thing I think that sometimes we forget, and maybe we think everybody knows it, and that's the value of flush rate non-rebreather, particularly in those patients. So a lot of patients are mouth breathers, and high flow nasal cannula, as much as we love it and it's fancy, it just doesn't oxygenate them as well as a mask with the oxygen cranked all the way up. So I encountered this the other day when we had a patient who was very sick, and they're like, well, they're on non-rebreather all the way up. And I go in the room, and just listening, you can tell that it ain't all the way up. It's at 15 liters. And our wall can go up past 40 liters per minute. And the patient's sats came right back up to 100 prior to intubation, a patient that we couldn't use non-invasive ventilation on. And so I just want to put another plug here that I think that is one way to ensure that you get good oxygenation, which can also help with vasoconstriction and dilation in the pulmonary vessels, is just using that as another last ditch effort to try to get oxygen levels up prior to intubation and sort of during that phase. Even if you're trying to stave it off to get other therapies going, it can be a very useful thing.
Fantastic. Great tip there. So don't forget to crank your non-rebreather as high as it goes before you even start considering high flow or intubation or what have you. Dr. Morgenstern, any other tips, tricks, pearls, pitfalls when it comes to having to intubate a PE patient?
Yeah, I might just be restating what's already been said. I think theoretically, if you ask me on an exam, an awake intubation is the correct answer. But as Dr. Tillman said, it's just not practical for most of us. But if I had George Kovacs in the next room or Scott Weingart in the next room, I might ask them to do a proper awake intubation. Although honestly, I think that made a bigger difference in 2000 than it does in 2025 because we've learned a lot about RSI. And so I think as long as people are doing 2025 high quality RSI, which includes really good pre-oxygenation, which includes resuscitation and vasoactive substances going along, which includes ventilation during that apneic period so we don't have CO2 building up and we don't have more pulmonary vasoconstriction. It includes all the tools we have for first pass success. I actually think the difference within awake intubation is smaller now. And you've done a number of podcasts on the specific issues. So as long as we're doing high quality 2025 RSI rather than what I trained in 2000 RSI, then I think we're probably okay. The only plug, again, plastic between the cords is actually not that important in these patients. It's not a GI bleed patient where aspiration risk is high. So if I failed, would not be backing up to a BVM. I would go straight to LMA in these patients because actually that's doing almost everything that I need. And I think LMA might be one of the most underused tools in all of emergency medicine. So that might be the only other adjustment that I would do. I'm happy to jump to an LMA very early for any signs of failure.
Good point. And now a word from one of our sponsors, Quinty Health. Are you looking for a fresh start in emergency medicine or the right place to take the next step? At Trenton Memorial Hospital, they offer more than just a job. They offer a collegial team, excellent compensation, and real support. If you're an experienced EM physician looking for a well-run collaborative department, this is a rewarding, high-volume environment where your skills are valued. If you're early in your career or transitioning from family medicine, their hands-on mentorship program has your back. Work side by side with seasoned emergency physicians for 4 months with structured onboarding designed to build your confidence and clinical independence. Earn up to 600,000 Canadian annually with 75,000 in incentives plus relocation, licensing, and immigration support. Trenton Memorial Hospital is located near Toronto, Ottawa, New York State, and Vermont, and just minutes from beaches, wineries, and outdoor adventures. Visit quintyhealth.ca, that's QUINTE health.ca, and click Physician Opportunities to learn more. All right, I think that's enough about intubation, oxygenation. I want to get into supporting the blood pressure. We touched on this in our discussion about intubating. Let's say we're back to our 30-year-old who's peri-arrest. We haven't intubated the patient. How do we support that blood pressure? So I've heard all kinds of arguments that we should avoid norepinephrine, which Dr. Tillman had just mentioned he might use prior to intubation. I've heard that you should use norepinephrine, but only at low doses. I've heard that vasopressin should be the first line. Dr. Westifer, what's your take on supporting the blood pressure? How do we best do it in these peri-arrest PE patients?
We're a dogmatic bunch, right? All these you have to avoid, you must do this. I think this comes down to evaluating your patient and really thinking critically. Unfortunately, there's no algorithm here to guide you through this because patients are still on a spectrum. Some of them will have biventricular heart failure and they present with a really high risk PE that's catastrophic. Some people will be a young 30-year-old who has a vigorous LV function, who may have had a viral illness and is actually a little bit dry and also has a failing RV. So I think the steps here is number one is, we're really hammering this in here, but it's so important. Is the PE the cause of this? Is their blood pressure low? Are they in AFib with RVR that needs to be cardioverted out or something else? Is it really that we think the PE is so big and they are so decompensated that this is their PE? Because that's going to be a big difference. Number two, I don't bolus these patients with fluids empirically. It's sort of our go-to, a little hypotension, a little bit of an elevated lactate, and we rush in with a couple of liters of fluid. And I think we do need to temper our desire to kind of do that and normalize the numbers and think, okay, what is the best way forward? And we don't have any randomized controlled trials really looking at what do we do, which vasopressor, how much fluid, do we give diuretics? And so looking at the patient and really thinking, do they appear to have high right-sided pressures? And it's not like we're sitting there with our POCUS estimating pulmonary arterial pressures, right? Like I wish I could, but I'm not doing that in the ED. And so thinking about, okay, is their IVC super plump? And usually I'm not a big IVC fan. I don't think it adds a lot of value in most patients with fluid responsiveness, but here I'm actually looking at it to kind of get an ascertainment along with my actually looking for some JVD, et cetera, to look, are they backed up? And sometimes I will have already given a little bit of fluid because you have that diagnostic uncertainty up front. And then I go with norepinephrine. We don't have any great rigorous trials. We've got a lot of animal models that look at the benefits of vasopressin in, smaller mammals, but I don't have any convincing evidence to me that that is a first line right off the bat, particularly because it often has to come from somewhere else. I want to control their blood pressure now. I want to support them now so they don't arrest. And for me, that's norepinephrine. And everyone's comfortable with it. And so we can at least start that. Maybe we don't crank it up super high from the get-go, but it's right there. It's immediately accessible, and we all know how to use it. Then if I need to add something on, I'm going to do what I usually do, which is add on vasopressin if I need to. There's theoretical benefit there. But for me, I think that sometimes when we overthink things, especially because they're different or fun or unique to PE, we really lose sight of doing the thing that is going to have the most immediate benefit from the patient, that the team is comfortable and can execute well and smoothly.
That was freaking amazing. Thank you. So just to summarize there, we again need to decide, is the PE the cause of the hemodynamic instability first? Because if these patients are also septic, then they may very well need fluids. If you've decided that it's just a PE, you want to try and avoid fluid boluses. You might want to look at the IVC to see if it's distended. That might help you in terms of figuring out if they do need fluids. In terms of vasopressors, norepinephrine is your go-to. Hopefully, a low dose of norepinephrine will stabilize the patient. If it does not, rather than cranking the norepinephrine, then move on to vasopressin. Excellent. So we've talked about oxygenation, we've talked about ventilation, we've talked about blood pressure support. Of course, there is a clot sitting there, and we want to lyse that clot in almost all of these patients, especially the peri-arrest patient. The only wrench in this decision is that now we have these options to call a surgeon to have a surgical embolectomy, or to call IR to have some catheter-directed lysing of the clot. There's all kinds of different options now in terms of how to get rid of that clot besides just giving systemic thrombolysis. So Dr. Westifer, how do you make that decision of whether to lyse right now or to call your IR department or call your surgeon to try and bust that clot?
Well, the first part is really easy. If they're dead, I'm going to lyse them right then and there because, I'd love to say, oh, we'll do ECMO in the emergency department and then transfer that, but that becomes a whole mess. And there's no evidence behind that. Even the evidence behind, full dose thrombolytics is really founded on very small numbers in an initial trial. But here, if they're dead, I'm going to thrombolyse them. If they are peri-arrest, and I really don't think that they could make any sort of transport, whether it's upstairs or to another hospital, that is another case where I evaluate their contraindications, because if they're dead, there's no contraindication that I'm not going to lyse them. But if we're sort of grappling with decision points, I got to suddenly think, okay, do they have any major contraindications? There's a whole list of contraindications to thrombolysis that I'm sure you can put in the show notes, but there's relative contraindications and there's absolute contraindications. And so maybe they had a history of a head bleed, but it was a long time ago. Those are patients that it's not an absolute contraindication to necessarily thrombolyse. And so I'm going to be thinking, okay, what is their contraindication to anticoagulation, and how soon do I need to do something? It also becomes easier if you have no access to those catheter-directed therapies. So for example, if I am at a critical access hospital and I have a long transport time, my only option is thrombolysis. And so in that peri-arrest patient, I'm going to consider, okay, there's no absolute contraindication. I'm going to thrombolyse them because I have no other option, and I don't suspect they are sort of on that cusp of really decompensating. Whereas the patient that is looking relatively okay but has some markers that put them in that like very high risk category but are stable on some degree of pressors, maybe I have time in that patient to stabilize them for a transfer. The third is it a clot that is amenable? Theoretically, if it's a high-risk PE, again, I need to be looking at that CT and seeing something very proximal. Because again, I'm not going to lyse or direct somebody to a catheter-directed treatment if it's not a very proximal clot, because that's not what's going to be causing their high-risk PE and their presentation to that. So to summarize, it's if they're in cardiac arrest, I'm going to lyse them. If they're not, but they're very high risk peri-arrest, I'm going to think about their contraindications to systemic thrombolytics and my accessibility of catheter-directed treatment. These are patients that are all going to need something in the near term, not the next day. And so those are patients that I'm going to think about, can I get something done in the next few hours or however proximal I think that their deterioration could happen, and then consider, do they have a contraindication to systemic thrombolytics? If they do, then I'm going to really push to get catheter-directed treatment. And if they don't, then I'm going to consider what availability do we have for catheter-directed treatment? Is it amenable? And then engage in shared decision-making regarding the systemic thrombolytics.
Beautifully summarized. I want to talk a bit more about contraindications and bleeding risk. So that's in the peri-arrest patient. That makes total sense to me that really it's only absolute contraindications that you would not lyse. What about the patient who is high risk? Again, there's this huge spectrum within the high risk category. The patient who fulfills the definition of high risk, but they're otherwise not looking too badly. Do you use things like the PECH score, which is apparently a validated score that looks at the likelihood of intracranial hemorrhage in patients with pulmonary embolism who are treated with thrombolytic therapy? Do you use that score to help you decide? There's like the has bled score. Do you just use your Gestalt? Obviously this is going to involve, if you can and have time, a bit of shared decision-making with the patient and or their family. But how do you decide on bleeding risk in the patient who's not in arrest or peri-arrest? Because we've decided already, if they're arrest, you're giving thrombolysis. If they're in peri-arrest, you're only going to not do thrombolysis if they have an absolute contraindication. Dr. Tillman, any thoughts about assessing bleeding risk in the lower risk of the high-risk category PE patients?
Yeah, I think your introduction has highlighted the challenge very well. I use more of a Gestalt-based approach just because when you're trying to have shared decision-making, you're saying, your risk is 3% or 5%. As humans, we can't really apply that well. So it's discussing you have these things that are going to put you at a higher risk of bleeding. And the question we're going to be discussing together is the risk of bleeding to you as a person, the implications of intracranial bleed, having some functional deficits. Is that risk something that is a greater concern to you than the risk that this may actually kill you? And that's how I look at it, as opposed to really saying, 1 in 30 people who I do this to are going to bleed into their brain, because humans just don't understand odds. And I know Justin has talked about this numerous times about how do we convey things with odds and why that's just a really weird way to try and talk to people. So I do very much use a gestalt and talk about why do I even worry about bleeding risk? Where are the implications of bleeding risk? And then I frame it once we sort of get down to the nitty gritty. Look, the only risk factor you have is your age. That's quite a low risk factor. It is far less likely you will bleed than you will die versus your risk factors. You have metastatic cancer to your brain. It is very likely you will bleed into your brain and bleed a lot. So even if you survive this, you will have functional impairment. So that tends to be the way I approach it rather than using a specific score. But I'd be very interested to hear how Justin and Lauren have these discussions with families.
I think the big thing is you need to have a sense before you walk into the room. And I'm not a big fan of scores. I've ranted a lot about scores, but I think prognostic scores are way better than diagnostic scores. We use a lot of these diagnostic tools in emergency medicine, and that can be a bit of a disaster. But having a sense of risk for us, not to convey to the family, makes sense, or just know it from the studies. Because I think we generally have very little sense. Like if you ask me, what is the chance of a random patient dying from their PE, on the spot, I'm going to panic. Like I just don't know what it is. Give me an hour in front of the computer, I can figure it out. And so I think you need to have some of these numbers in your head ahead of time or a way to look them up. And so that's one of the reasons for the scores. I don't care how accurate the score is if I can get a general ballpark. Are we talking 1%, 10%, 50%? They're going to be accurate enough for that. And then, I'm just looking if the score, the risk of death and bleeding, are they in the same ballpark or are they dramatically different? And then it becomes pretty easy. If they're in the same ballpark, we need shared decision making. If they're dramatically different, I can make the decision for the patient.
Excellent. Yeah, we'll have the PECH score in the show notes. But I think it's important just to have a sense of what's in the score so that you, again, can kind of get a general sense of what their bleeding risk is. Some of the things on the PECH score are pre-existing peripheral vascular disease, age greater than 65, a prior stroke, prior MI. So it's actually just basically cerebrovascular event and age over 65, if we want to simplify it. Dr. Westifer, you can have the final say on this one.
Oh, good. No. I think that it's the same that we've all sort of said. There's shared decision making, and there's also the patient valuation of like, how sick are they? How much time do we have? And how much are those factors really at play? 65 is a cut point we love in terms of age, but it's really meaningless. If you're 64, if you're 66, we see people who are chronologically very young, but physiologically, much older. And so I don't really believe in a lot of those strict cut points. I think that, if you're 90, your risk is obviously different than if you're 65, but it's harder to know what is a 70-year-old versus a 65-year-old. Rant over. Back to thrombolysis. So we have a whole PE protocol that manages who is low risk, who might be eligible for a PERT discussion, et cetera. And it has some simple things in there, one of which is clinical judgment about benefit and risk. I think that that's important. Obviously, like the closer, more in proximity a head bleed is, like if it's a traumatic bleed that was a month ago, that's different than one that was a year ago. And a hemorrhagic stroke is obviously very worrisome regardless of when it happened. But thinking about which of those items it is and knowing some of those big things to ask for. And then again, thinking, so what if they do decompensate? Say I don't do this, what is their salvage plan? Because if you've decided that they're really not a candidate, you really need to be thinking, is this somebody who can go for embolectomy? How do I get them evaluated by a cardiac surgeon? Is this somebody who could undergo a catheter-directed thrombectomy? What is my salvage plan going to be if it's not thrombolysis? And figuring out how can we stabilize the patient to get to whatever that definitive treatment plan is. And so I think it's evaluating where you are, your local resources, what you have in a larger catchment center, and where you think that patient stands in your ability to temporize their hemodynamic and respiratory status. The last thing I got to say, Anton, is again thinking we worry so much about bleeding risk when we talk about thrombolysis. We don't think about it when we initially bolus that patient with heparin. And we know the low-hanging fruit, unfractionated heparin is associated with more bleeding than other anticoagulants. So I think we can have all these esoteric discussions about risk of bleeding with thrombolysis, but this is a minority of the patients. If you're actually worried about bleeding in patients with PE, you got to do the simple things right, which is usually going to be a different anticoagulant than unfractionated heparin.
Yeah, I think that's going to be one of the great take-homes from these two podcasts. That's a game changer, is that IV unfractionated heparin has actually very little role in these patients because of higher bleeding risk. I just want to point out as well that for lysis, we really have to think about bleeding risk very differently in these patients compared to stroke patients. Because when we're lysing a stroke patient, the risk of intracranial hemorrhage is much higher than when we're lysing a PE patient. And I think that's just something that we have to keep in the back of our minds when we're deciding about lysis or not for PE patients. Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50. So now that we have a good idea of how to risk stratify patients for bleeding risk and who we're going to lyse, let's say we have a patient who has a high bleeding risk and we're thinking more about catheter-directed thrombolysis or surgical thrombectomy or mechanical thrombectomy. Dr. Morgenstern, can you give us the bottom line for the evidence for these non-systemic lysis procedures for PE? So I seem to hear about them all the time, and I just have this sneaking suspicion that because they're all supported by the makers of the devices that they use, that I'm not sure I really want to trust all the studies that have come out. What's your take on the evidence for surgical embolectomy, surgical thrombectomy, catheter-directed thrombolysis, or mechanical thrombectomy compared to lytics for these sick patients with PE?
Yeah, so depending on how you look at this is either an incredibly easy or an incredibly difficult question to answer, because at this point, there's like nothing to say at all. There is essentially no real science. I think probably Lauren's opinion is at the top of our evidence pyramid here, because that's what we have. We got expert opinion. There's really nothing that looks at what we really need. Not a single trial ever has compared any of these devices to TPA through a peripheral IV. Essentially, there's one RCT that compared these devices to peripheral heparin, which is not really the same category of therapy in my mind. There's one RCT, the Peerless trial, which really shows no difference between catheter-directed thrombolysis and mechanical thrombectomy. But aside from that, you have observational trials with no comparative group at all published by the companies trying to sell these drugs that often show things like the RV size got a little bit better or some other marker, but without a control group. There's no clinically relevant information in dozens of papers that I've read so far because you just don't know what would have happened if you had treated them with anything else or just standard care. I think there'll be some argument out there. In the last episode and a little bit already today, we've heard that both of our other experts do like these fancy techniques. And I think on paper, they make some sense in some patients. But personally, I'm a little cautious knowing the history of medicine and evidence-based medicine. I see expensive, invasive procedures that currently have absolutely not a shred of evidence of benefit. My baseline makes me concerned. My baseline makes me think that we should not be using these and we shouldn't be using these routinely. And honestly, I said last time, but I don't think they actually make a lot of physiologic sense. I'm not sure that directing thrombolysis directly into the pulmonary artery is any better than just giving it through a peripheral artery. That's different from actually taking the clot out to some extent. It makes me nervous to see them using more and more routinely. But when there's no evidence, this is why this is so complicated. I think expert opinion and I think judgment really matters as long as it's not highly conflicted and highly biased opinion. If you have a patient with significant contraindications to systemic thrombolysis and they're going to die, what else are you going to do? And it makes a lot of sense to go and pull that clot out. So the summary, the evidence is easy. There is none. We have no idea what we're doing. And I think somebody needs to be a voice of caution in that we have a lot of push from people who stand to make a lot of money. And these are expensive and these are invasive procedures. So I think there should be some caution. But if I have that really sick patient and Lauren, as the expert, says, I think I should get him to a mechanical thrombectomy, I agree with her. Until we have the proper RCTs, I think the key is we need the proper RCTs. We must demand appropriate science, but we're not there yet.
So that's the evidence-based answer. Dr. Westifer, you are part of a pulmonary embolism response team, or a PERT. And Dr. Tillman, you have to make these decisions in the ICU sometimes. What's your sort of practical approach? When would you pull the trigger on a surgical thrombectomy or mechanical embolectomy, or I can't even remember what all the different options are, but all these different invasive procedures rather than lytics?
I think as we talk about the literature base, I'm biased because I'm a researcher. I don't take any money from industry, just the National Institutes of Health for now. But this patient population is almost impossible to study and to randomize in a very quick fashion. You absolutely can't do the high-risk patients. It's essentially impossible. And then you get into so much heterogeneity when it comes to contraindications, the indication for doing the procedure. And like we said, there's so much spectrum here. So it ends up being a pretty heterogeneous group. And so I think it's very difficult to do that. The second is I also distrust a lot of pharmacy and industry funded stuff, but the devices have to get developed. And there are NIH funded trials ongoing now to kind of mitigate some of that conflict. But you have to get the approval and stuff first, just as a stepwise fashion of doing things. So I think that we're in sort of a no evidence zone for anything, including if you look at the original trials for lytics in these very sick patients. I think that it's very difficult that you would look at those studies if you want to apply the same evidence and be like, we're doing stuff without any evidence here. So for me, my decision point still, and I'm probably biased by following up the outcomes, but the patients that we tend to send, and this is all anecdotal, and I'm happy to change this when it's not proven, but our length of stays are very low in these patients. We can get them out because they come off of oxygen out of the cath lab, and they don't need to go straight to the ICU because we do aspiration, not the lytics. It's going to depend on where you are and who you're sending, and we try to be very selective about the sick patients going, not the worried well that have a little bit of bump in their troponin or BNP. And so I think a lot of this comes down to thinking about who are your consultants, and like anything, not over trusting this evidence base that's all industry funded without sort of a control setting. So for me, it's easy because I have access to a PERT team with experts, and sometimes they're biased too. IR might not want to come in the middle of the night. Cardiac surgery never wants to come in because they are really busy doing other procedures, aortic dissections, etc. And so I think however you can involve other people to offload that sole decision making is going to be really helpful. So your ICU, pulmonary, etc., to get people to figure out what is the best for that patient, because it's hard.
And Dr. Tillman, from a practical perspective, when do you pull the trigger on a non-systemic lytic pathway for these patients?
I actually think it's a very interesting question, but that's because also I am a scientist as well. Thinking of the options of surgery versus catheter, surgery is a very, 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 very rare choice for me in these acute PEs. Given a combination of the morbidity of these surgeries, speaking with our surgical team, we have a wonderful thoracics team. Like, if they're doing surgical embolectomies, those are usually for chronic PEs. It's very rare that this is a surgical disease. So those two things I sort of take off my treatment path pretty early on. I say either you're going to get systemic or there's a catheter going in. And then as Lauren highlighted, if I can't move them, it's systemic. So this question is in the person who I think is sick enough to need the clot removed, but not so sick that it doesn't need to come out now. Then I do agree with Justin in the sense that there's not a trial demonstrating one is superior to the other. And we're sort of left with, well, we have a sense of the natural history of a high-risk PE and the mortality risk. And we have a sense of the mortality out of the independent studies. And it does seem that if we do an intervention people die less. So I think we should intervene, be it systemic thrombolytics or catheter-directed. And then I'm trying to figure out what is going to have the lowest risk. I do have a lot of interest in mechanical thrombectomy, not because anyone pays me, but based sort of extrapolating, as we talked about in the last episode, the stroke literature and the potential hope that we can decrease the bleeding risk, as I don't really want to trade the cardiac complications of PE with a poor functional outcome. So I do have a chat with my interventional team when we have a patient who is sick enough that we want the clot out, but not so sick that the clot needs to come out in hour 1 or hour 2, but we have a bit of time for that to happen. So that's the way I look at it. As soon as it doesn't need to come out now, I'm having a conversation about thrombectomy through a catheter route, but not a surgical conversation.
Makes sense. I want to talk a bit now about the lytic dosing for the peri-arrest patient and how that might differ to the cardiac arrest patient, or if that differs at all to the not so sick high-risk PE patient. And it seems like the dosing is all over the place. I mean, your hospital is probably going to have your protocol, but there is some evidence to suggest out there that half-dose lytics are as good as full-dose lytics with a lower chance of bleeding. Should we be using half-dose lytics for all these patients? Should we be using them in cardiac arrest? Should we be using them for the peri-arrest patient? Dr. Tillman, we'll start with you. What's your take on how do you decide what dose lytic to give to the cardiac arrest patient, to the peri-arrest patient, and to the not-so-sick high-risk PE patient?
So as we established, the evidence of systemic thrombolysis is weak. And we're going from the weak evidence to talk about the evidence for the dose of the thing that we think probably works. And so this is really hard. The way I'm going to work back from cardiac arrest. If someone's in cardiac arrest, I'm going to be giving full dose thrombolytics. Why am I doing that? Because I'm not sure how much of that thrombolytic is going to circulate, especially if it took you a bit of time to either get the drugs or get to the diagnosis. So in a cardiac arrest patient, I'm giving the full dose thrombolytic. Once we step out of there, I like the idea of half dose or targeted dose thrombolytics. There's been some exploration on it. The studies are not large enough to create firm guidelines, but when we think of like the Moffitt dose, we're using a half dose. To me, it does intuitively make sense. This drug is going through your pulmonary circulation. All your blood goes through there. So you're getting a high concentration of drug to clot. And also the risk of having a bleed elsewhere is related to how much drug we give them. So if someone has a perfusing pressure, so we're not doing CPR, I will drop down their dose of thrombolytic. For me right now, that is giving a half dose of alteplase and then a full dose if someone's in cardiac arrest. I also accept that aside from TPA, there's TNK conversations now. And as I said in the last episode, I think we're going to be seeing more TNK just as the stroke literature is moving that way. It may change what our pharmacies stock. But right now, most of the evidence I've read speaks about TPA, speaks about alteplase. So that tends to be what I use. Although I do like the simplicity of dosing TNK and not having to have an infusion. Some of my colleagues may not like that as much because if you have an infusion, you can, in theory, stop it earlier if you think you've given them sufficient drug. So to summarize that, if your heart's not beating or you need CPR, I'm giving you a full dose. If your heart is beating, but I'm giving you a systemic thrombolytic, currently I'm giving half dose, but I'm very open to these ongoing conversations about more finessed titrated doses.
Excellent. I think that's a great simple approach. If they're in cardiac arrest, full dose. If they're not in cardiac arrest, half dose. And you do have the option of alteplase or tenecteplase, and that decision will probably depend on just what your hospital does.
I think I just have two things to add to what Dr. Tillman has told us. I think the peri-arrest patient, we can throw that term around, but it can be very, very different. So if I think the patient's going to die in the next 5 or 10 minutes, I'm probably giving them the full dose. But otherwise, I agree with you. Half dose is where to go. So peri-arrest can describe a large number of patients, and I think you got to be really cautious there. I think it's the other end of the spectrum that's really interesting. If you're a patient where our other two experts would be really thinking about catheter-directed thrombolysis, like you have time, half dose might even be too much. And that's what I really want these studies to show us. I never get this chance because I don't look after these patients myself. But if I was an ICU doc who was going to be in-house all night, I would probably push TPA as like 5 at a time every hour and just watch how the patients improved. Or you can do it as an infusion. You don't have to continuously push it. But it makes sense to build up to if you're going to aim for 50 over 12 hours, which is exactly what the catheter does for you. So I would actually be replicating the catheter with my own hand through a peripheral IV in those patients that is a possibility. But that is far, far, far from the guidelines. So most people listening to this, unless you're a researcher thinking about protocols in the future, should do exactly what Dr. Tillman was saying. I just think that there's a much bigger spectrum of possible treatment strategies as we try to figure this out going forward.
Yeah, good point. I mean, there has been talk about doing infusions. There has been talk about doing quarter dose, little aliquots until you get up to the half dose. And if you need more, then give more. None of these things obviously are well studied, but just to know that they're out there. I think if you just need something simple, though, I think we'll all agree that Dr. Tillman's approach is very reasonable. Dr. Westifer, you had talked about how IV heparin is overused and has a higher bleeding risk compared to low molecular weight heparin. I just want to try and clarify, is it all patients that you're avoiding IV heparin in the cardiac arrest patient? Because I think the guidelines suggest that you do use IV heparin in these really sick, high-risk PE patients. So could you just clarify for us when you might use IV heparin and when you might use low molecular weight heparin in these high-risk patients?
Sure, Anton. First of all, nothing is ever all or none. There is a role certainly for IV unfractionated heparin. So if it is a cardiac arrest patient, sure, we're already giving them thrombolytics. We can start the heparin whenever. Or I'm not usually doing that in the emergency department. Usually that I've thrombolyzed them. We got return of spontaneous circulation, whatever. I'm getting them to the ICU ASAP. So in those patients, the guidelines say you can give IV unfractionated heparin. I think that's fine because these are going to be hypotensive patients. Enoxaparin through a subcutaneous route, which is how we're usually comfortable giving it, is probably not going to be, there's some concern for absorption through the subcutaneous route in people on vasopressors or who are profoundly hypotensive. So in those patients, I am not giving low molecular weight heparin to because I'm worried that they will actually be able to get therapeutic on it via the subcutaneous route. So in all other patients, if I'm not immediately pushing thrombolytics, say they have time, they're going for a catheter-directed treatment, they know they're not going to go for any other surgery, they don't have perforated diverticulitis that they're also getting treated for, I'm going to give them low molecular weight heparin. That is not a contraindication for thrombectomy or even salvage lytics later. So in the cardiac arrest patient and the profoundly hypotensive patient on vasopressors, IV heparin. For everybody else, absent another planned surgical invasive procedure, not catheter-directed treatment, then those patients are going to get a low molecular weight heparin from me.
Fantastic. And if you do give IV heparin, I've read different things about the length of time from lytics until you give the IV heparin. Some people say delay it 2 hours. Some people say delay it 6 hours. And I think the reason why people recommend delaying it in the first place is because there's this idea that if you give the IV heparin immediately after lytics, you're increasing your risk of bleeding way more without really much benefit. Could you tell us what we should be doing in terms of the timing of IV heparin in these cardiac arrest patients who have a return of spontaneous circulation?
Delay it till they get to the ICU.
Somebody else's problem.
Good answer. Okay. All right. Excellent. That's simple. I like that. So bottom line there is IV unfractionated heparin we use in the cardiac arrest patient, but we're actually not going to be using it in the ED. We're going to give them time for that lytic to circulate, and they're going to get that IV heparin in the ICU. Someone else is going to give it to them. So we actually don't have to worry about IV heparin at all in the emergency department. And then for all other patients, except for those going for a surgical procedure for some other reason, all other patients will get low molecular weight heparin, which simplifies things very nicely.
And you can give, again, low molecular weight heparin and thrombolytics are not a contraindication. It's just usually they're hypotensive or there's some other reason that you're giving the thrombolytics. So for example, the Top Coat trial with Jeff Klein had intermediate risk patients, which are usually not the peri-arrest patients, right? By definition, they're not high risk. And there he preferentially switched them to low molecular weight heparin prior to tenecteplase. So it's not there's a contraindication and you can't give lytics later if you started with low molecular weight heparin. It's more that these patients are so acutely ill that you're worried about the absorption that is why you're giving the heparin.
Makes sense. Great. For those patients who start out as an intermediate PE, like the case we've had, and then end up as a high-risk PE, they've already received their low molecular weight heparin, then you would just give them lytics.
Yep. Or they can go for catheter-directed treatment. Again, that is often perceived as a contraindication, and it's not.
Got it. Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES. All right, we've covered oxygenation, we've covered blood pressure support, we've covered lysis and anticoagulation. The other management goals that we should address in these high-risk PE patients are trying to reduce the afterload, treating the acidosis, and dilating those pulmonary arteries if we can. So, Dr. Morgenstern, to reduce RV afterload, we try to avoid PEEP, as we discussed already. We try to avoid big crystalloid boluses, as we've discussed already, and we avoid hypercarbia and acidosis whenever possible. For the acidosis part, we know that the more acidotic the patient, the worse the pulmonary vasoconstriction and the worse the RV does. In patients with shock in general, we know that giving bicarb has never really been shown to be effective for patient-centered outcomes. But what about in the specific case of Peri-arrest PE? So let's say the pH is 7. We know that acidosis is going to be impairing contractility, reducing cardiac output, and may even precipitate a hemodynamic collapse. Do you recommend giving bicarb in the Peri-arrest PE patient?
There's three major factors in trying to keep the pulmonary arteries open. It's keeping the oxygen up, keeping the carbon dioxide down, and avoiding acidosis. And I always prefer to just glaze over the acidosis part of that talk because, Lord knows what you're supposed to do. Bicarb, I think, rarely makes sense in medicine. It creates a lot of CO2, and so in order to be effective, you have to be able to blow off that CO2, and if you're critically ill, you generally don't have a lot of room to increase your minute ventilation. Now, PE patients tend to have healthy lungs under there, so they might be better candidates than our average patients, but if they're hypoxic, there's going to be VQ mismatch, and so you're not going to be able to blow off that CO2, and so it's unlikely to be effective. And on top of that, the only way to give bicarb is by giving IV fluids, and we've already talked about IV fluids not being a great idea. There's a lot of literature that says boluses of bicarb don't do anything. So you have to do an infusion with IV fluids over time to really get any kind of effect. Personally, my gut is that we shouldn't use bicarb. I have not used it clinically. I think the goal is to manage the cause of their acidosis. They're not acidotic from a lack of bicarb. They have not been, it's not like they're not taking in bicarb. They're acidotic because of their shock. They're acidotic because they're hypoventilating. And so I think if you focus on the underlying causes of the acidosis, you're going to get a lot further than you will by just giving bicarb.
Fair enough. That makes total sense. Dr. Tillman, as an intensivist, I'm sure you've reached for bicarb once or twice in your career. So you're more familiar with the use of bicarb than most emergency physicians are. Would you ever reach for bicarb in a PE patient?
Would I ever? Yes. But would I routinely? No. And it supports much of what Justin just said there, is most of our patients are acidotic from an underlying cause, and we're treating the underlying cause. And it's the same thing in a PE patient. The situation that gets the would I ever yes has to do with, there's a nice trial in Lancet that looked at giving bicarb to critically ill patients. And it does appear if someone both has a low bicarb, acidosis, and renal failure, those patients may actually have improved outcomes. So if someone has had a PE for a long enough time that they have now developed renal failure, then maybe I'll start trying to mess with their acidosis there. But I also have the luxury of I can give high concentration bicarb. So like I can run it at 25 cc's an hour. So I'm not ramming these people with fluids. There's a lot more things we can do in the unit. But these interventions, this isn't usually a day one thing. Like to have that really set in renal failure, this is day 3 sort of things we're dealing with. So that's why I say, have I? Yes. Would I routinely? No. I think the key message is we are trying to treat the underlying cause of the acidosis, and that's the RV dysfunction. So manage the RV. And it turns out that acutely changing their pH probably isn't the thing that's going to fix it. It's dealing with the clot and dealing with the pulmonary vascular resistance.
All right. So bottom line is, in the emergency department, there's pretty much no role for bicarb, even in these really sick PE patients. It might be a consideration later on in their ICU stay when they go into renal failure. Then there's the pulmonary artery dilators. I've heard about nebulized milrinone, nebulized nitroglycerin, nebulized nitric oxide. It kind of makes theoretical sense that these medications do dilate the pulmonary arteries, and that's what you want in these really sick PE patients. Dr. Tillman, what's your take on using milrinone or nitric oxide or nitroglycerin to dilate the pulmonary arteries in PE patients?
So this is one of my favorite parts about taking care of patients with PE is the weird pulmonary vasculature stuff. Like that conversation about vasopressin, it's totally theoretical. Will I force you through it on my rounds? Oh, you bet I will. And the same thing comes up here, but my practice is if someone has been intubated for their PE and is in shock, so they're a high-risk PE, they've been intubated, they're with me of ongoing management, I am starting a pulmonary dilator. I usually start with inhaled nitric oxide. We're outside of the land of high-quality RCT, so I'm not going to go quote an RCT at you here. The reason that I choose to start with nitric oxide is the sort of the bench research here, right? Like we know that the nitric oxide is going to get to the alveoli that are oxygenated, so it's going where the air is going, and it's going to dilate our blood vessels. It also doesn't have the side effect of both our milrinone and dobutamine, which can be systemic vasodilation. Because remember, we're trying to dilate the vascular system. We're not trying to dilate their whole body. So I start with a pulmonary vasodilator in these sick patients, which is inhaled nitric. And if they're truly in end organ failure, they're not making pee, it's a really sick patient, and we're doing all the other things, so they're either getting a lytic or their clot's being pulled out, then I will add on a systemic agent. Is it milrinone or is it dobutamine? You can write each of those names on a coin and flip it. There's a really good RCT comparing the two in cardiogenic shock, and it does not matter. I like to use dobutamine because you can turn it off faster. So when I think of it, if someone has ended up intubated because of their PE, they have a hemodynamic compromise, or they have refractory hypoxemia, I'm starting them on inhaled nitric oxide. Once I've managed to stabilize out their blood pressure a bit more and they're not making pee despite that, then I'm going to add on either dobutamine or milrinone. In my practice, it's more often dobutamine just because it's an easier to turn on, turn off drug. So I do often use these in my sick PE patients, but in the grand scheme of critically ill patients, like this is much more of a rare patient. I manage a couple of these patients a year in the unit. It's not like every day I get to wheel out the tanks of I&O and go to town.
All right, great. We've covered the peri-arrest patient. We've covered the not so sick patient. We've talked a little bit about cardiac arrest, but I want to talk a little bit more about cardiac arrest because most of the time we're seeing a cardiac arrest, we have no idea that the patient even has a PE. These are undifferentiated patients. We might think about a PE when they come in with a sudden collapse and if they're in a PEA arrest. So I want to talk a little bit about that cardiac arrest patient where we don't have the diagnosis of a PE yet. We don't have a CTPA. We suspect that they might have a pulmonary embolism. Dr. Morgenstern, when should we pull the trigger on giving lytics for a presumed PE in an out-of-hospital cardiac arrest patient?
Man, I don't have a brilliant answer here, and you might tell me I've never had a brilliant answer to anything, but it is especially true here. This is really, really hard. I mean, we know that PE isn't important, but it is a minor cause of out-of-hospital cardiac arrest. I've seen estimates as high as maybe 5%, but like autopsy studies are really hard to determine causation here. And we know that just throwing around lytics in all arrests is not a good idea. It doesn't help. Bedside ultrasound, not really helpful once an arrest has happened. You're always going to get some degree of RV dilation. So for me, this is entirely based on history if you're lucky enough to get one. If there's anything that points me in the direction of PE, if there's a good story, if there was a sudden onset of dyspnea before the arrest, if there's a history of PE, clear PE risk factors, maybe the one thing on physical exam, signs of DVT, or maybe DVT on ultrasound, if I was getting that far, might push me. I'd be cautious in any shockable rhythm because PE almost always causes PEA arrest, not a shockable rhythm. And obviously be very cautious if the arrest is already looking futile, because I think the biggest thing, I look through this literature a lot, and the biggest thing that surprised me in this literature is just how good the outcomes are for PE patients when they're given lytics in arrest. And there's going to be some selection bias there. But if you look at the PIAPET study that sort of started this all, TPA and PA arrest, 87% of patients were alive and well at 3 months. These are arrested patients. PEA arrests, 87%. That's an absolutely astounding number, but it causes a problem for us because if you read the guidelines, these guidelines say you should run these codes for a very long time. The ESC, or the European guidelines, say that once you give a lytic in an arrest, you should run the arrest for 60 to 90 minutes after that point. And with outcomes as good as that, 87%, yeah, that actually makes a ton of sense. But that really complicates things when you're starting to pull this trigger here, because there is a lot of cost and a lot of harm with running a code for another 60 minutes on this guess of a possible PE. And so I think it's really important that we do pull the trigger if you're going to get an outcome like 87% survival at 3 months. But I think we need to think of the costs and the harms of running long codes as well.
Any comments about cardiac arrest when we don't know that there's a PE?
Yeah, I mean, I think that one of the big things is not to forget just the abysmal outcomes with regards to how long the duration is of arrest and all of those other things that go into risk stratifying outcomes in cardiac arrest. Because sure, of those that got the lytics, the survival was very high, but there's so much selection bias that goes into that. And so I'm going to be selecting patients that have had a very short duration of arrest. This is not the 85-year-old who has had 35 plus minutes of downtime, 5 pre-hospital epinephrine, and still has asystole or PEA. The second thing is that PEA almost always is profound hypotension. We call it PEA, but it's profound hypotension. So in those patients, pulse checks have been out of the guidelines for years and years. I don't do pulse checks, but I will put in an A line in those patients just to really ascertain that waveform and do an ultrasound to see, is there any activity in there? Because I'm just treating the hypotension in those patients. And if I see that there is organized activity and they're just very hypotensive and they've had a short duration of arrest or other good prognostic factors, they're very young, the person that you're really going to spend hours and all of your resources on, that is the patient that I'll do the thrombolytics in.
Fair enough. I want to get on to just our last topic, and that is the pulmonary embolism response teams, or PERTs. And Dr. Westifer, you are on a PERT team, so you might have a little bit of a bias here. So I'm actually not going to ask you about this, although I'm curious what your opinion is. In Canada, we do have PERTs in Vancouver, Calgary, Winnipeg, and Ottawa, I believe. And they all have guidelines with indications of when to actually call the PERT team for high-risk and intermediate-risk PE patients. Dr. Tillman, let's start with kind of the evidence. What does the literature show when it comes to the efficacy of PERT teams? And do you think we should strive to build PERT teams in all the large centers across the continent?
Really good questions. And the evidence sort of links to whenever we talk about creating any specialized teams. So there are both benefits and things we could consider harms. The nice things is it looks like people are getting anticoagulation sooner, and the really sick patients probably do better. So it's decreasing 30-day mortality in those really sick patients. The harms there is we're probably doing more. So there's probably more catheter-directed therapies. I think every time we put a catheter in, we will just pour one out for Justin at the side, because it seems that these are people with specific interest and they're up to date in the literature. They hear about the new therapies and they're like, well, we don't have great evidence, but this is what's coming forward. And whenever you sort of create a new team, there's going to be costs with that. So this is more costly. And it's likewise when we create any subspecialized group, you're pulling that disease out of the common management pool of other clinicians. So you will start to de-skill some of your other clinicians. And really the question then comes down to, do the potential costs, both financial and from a de-skill standpoint, do they outweigh or are they acceptable for the benefits, which is potentially treating faster, and then the sickest potentially improving their outcomes? And this is really a discussion we have for any subspecialized therapies. It's like when we start having STEMI bypasses, some hospitals don't have as much exposure to MIs, or I'm a trauma team leader, so the emerge docs at my shop see far less severe injury. So it's always these pros and cons that we have to deal with and see what works best in our institution, in our region, and for our patients.
Yeah, I mean, obviously, we've talked about it a lot. These patients are very complex, and I would love to have an expert to help me. I would absolutely love to get Lauren Westapher on the other side of the phone every time I had a really sick patient in front of me, or really just any day. I'm happy to chat. But I'm not entirely sure. And I think one of the big problems you can't tell even from a study, and we could debate all the studies all we want, but that's less important here. But like, what about the bigger system issues? Like, why PE in particular? Why don't we have a sepsis team and a hypoxia team and a CHF team and a cardiogenic shock team? We should have a suicidal ideation team and a homelessness team. There are hundreds of complex decisions we have to make in emergency medicine every single day, very complex decisions. And we could make a team of experts for each and every one. But the problem is the massive costs of that. And then you're taking away those resources from other areas of medicine. If everybody's on call all the time for everything, there's an opportunity cost that needs to be considered. So from an evidence-based medicine standpoint, I'm not convinced at this point. If I was running our healthcare system, I probably would not be creating these teams. If you had one, if I could get one, I would talk to them every single time, 100%. And that's the complexity here. It's a health systems issue. And so I think for the clinicians listening, it's easy. If you have access to one, you listen to one. But if you're a leader, I think that you should take a lot more time to read this literature and think deeply on whether this is the opportunity cost is worth it in the creation of each specialty team that you could possibly create.
Some very interesting opinions on pulmonary embolism response teams. Lots to think about there. Before we have the home stretch here, any other comments about managing the high-risk PE patients?
Let's reiterate, because I think at the end of a podcast, we spent a lot of time talking about how complex all this is. But I think to reiterate, for the average emergency doctor, you know how to resuscitate hypotension. You know how to resuscitate hypoxia. So actually resuscitate these patients like you already know how to do. And I think you'll do very, very well. And I think we can up our game by just remembering not just PE, but lots of patients can have RV failure. It's rare, but it's important. And just thinking about those three big things. Think about IV fluids. Think about exactly the level of PEEP, and think about the decision to not rushing to intubate. And I think that simplicity will probably help us a great deal.
Yeah, I think that is brilliant. Just simplifying that we should do what we do best, which is resuscitate patients, and just think about those three key differences in these PE patients. All right, in the show notes, we're going to have algorithms for the intermediate high-risk PE patient that we talked about in part 1, for the high-risk PE patient that we talked about in this podcast. I recommend for everyone who's listening to the podcast, please head over to emergencymedicinecases.com to review those algorithms. And I'm certainly going to keep these algorithms in my phone that I can access easily on shift when I do encounter one of these sick patients. It's important to remember that PE is a dynamic condition with management strategies that can change within an hour, and there's still a lot of gray area in the management of these patients. So use your clinical gestalt, take into account the patient values, do a thorough risk-benefit analysis. These are all paramount in making management decisions in these patients. Reach out for help when you need to. Thank you so much for your time, your efforts, and your expertise. It's such a pleasure and a privilege to have all three of you on the show. I kind of feel like we should have a group hug, but unfortunately that's impossible online.
Take care, buddy.
Thanks, Anton.
Awesome.
Before we go, I forgot to mention a couple of items. One is that I invited Ian Chernoff, one of EMCase's POCUS gurus, to tell us everything we need to know about PE and POCUS, and he recorded an amazing segment for us, but we ran out of time on this two-part series, so I decided to publish it in our upcoming EM Quick Hits podcast, which will be released on June 3rd. So for those of you who are interested in POCUS and PE, please go and listen to the next EMCase's Quick Hits podcast, June 3rd. And the other thing I wanted to mention is that May 23rd is the last day that you can get access to the most recent EMCase's Summit talks. The video streaming packages include an ebook summarizing the talks and CME accreditation. You can get it all at emcasessummit.com. So that's not the EMCase's main website. That's emcasessummit, all one word, .com.